All right, it is just past the top of the hour, so we will go ahead and get started. I'm going to try and multitask here and admit the participants and start at the same time. So bear with me if I pause for just a moment. I'd like to welcome you all to our Pediatric Medical Recognition Community of Practice call today. My name is Lisa Gray. I might be a new face and new name to some of you. I am new to the EIC full-time as of July this year. I participated in version 1 the last year of the program in a trauma capacity, but I'm now working with the EIC, so
Lost you, Lisa.
I'm excited to learn from you, get to know you better, and hear the exciting things that you all are doing in each of your states. I have had transitioned to taking on facilitating these calls in the future. So future communication around scheduling and appointments and Zoom links and so on and so forth will come to me. So if I missed you on the first distribution list, I do apologize.
Pretty much all done today.
If you haven't muted your speaker, if you could please mute yourself if you're talking.
And massage it, and then get Kelly to put eyes on it for I's and T's and stuff like
So
that.
yes, so as Kate mentioned, we'll ask that everyone mute their phones or computer, and we'll go ahead and get started. First, I'd like to start with acknowledgements and disclaimers. The EMS for Children Innovation and Improvement Center is supported by the Health Resources and Service Administration, also known as HRSA, of the U.S. Department of Health and Human Services, HHS, as part of an award, and you'll see that award number or number and lettering here, totaling $3 million with 0% finance with non-governmental sources. The contents are those of the authors and do not necessarily represent the official views and endorsement by HRSA, HHS, or the U.S. government. Just a quick agenda.
Whomever is on their phone, if you could please mute. We're hearing some sirens in the background.
All right, there we go. Thank you very much. All right, today's agenda. I'm going to give just a little bit of brief background and level setting, and then we are going to hear from our colleagues in Texas. Fatma Diouf and Sally Snow are going to share their experiences from Texas. So lots of exciting information today to come. So a little bit of background and aim of the community of practice. The work we're doing all is part of our EMSC Performance Measure 4, and that performance measure states that by 2022, 25% of hospitals are recognized as part of a statewide, territorial, or regional standardized program that are able to stabilize and or manage pediatric medical emergencies. An overview of the collaborative that started as the Facility Recognition Collaborative between April 2016 and December 2017. We all are striving to achieve a goal of all children getting timely access to emergency departments that are ready to provide immediate and appropriate care based on national guidelines for the care of children in emergency departments. That SMART aim is on your screen, and you can see it reads that by December 1st of 2017, we will have an increase by 50% the number of states that have developed and approved an implementation plan for the recognition of EDs who are ready to stabilize and or manage children with medical emergencies based on the 2009 Guidelines for Care of Children in the Emergency Department. Moving on to the transition to this medical recognition program, Community of Practice, that started in 2019. We now have quarterly calls, and really these calls are 100% focused on supporting each of you in your states and individual roles on how we can help, support, and learn from you for ongoing activities. Of course, sharing of best practices and troubleshooting challenges. Many of us face the same barriers and challenges. Many of us have, acknowledging that our states all look very different, many of us face the same challenges and barriers in moving forward in some programs. So really just an opportunity on these webinars to share successes and challenges, learn from one another, network and relationship build, so we all have just what it is, a community of support and colleagues to help move this important work forward. All of the webinars that we have on a quarterly basis are archived on our website. That link is here. And I'll take this opportunity to also note that we will be continuing to have our community of practice in 2021. So please be thinking of topics or anything that you think would be relevant to help you in your practice each day. I haven't sent the 2021 dates yet, but they will continue on the 4th Wednesday of the month at the very same time. So be on the lookout for that appointment to come. You also see on the screen here now an overview of where we're at as a system, as a country. There are now 17 states with pediatric recognition programs in place. You can see those listed here on your screen. Kudos to the new states who have joined this list since the last time we had a call in July. Indiana, Wyoming, and Texas are all now joining, so very proud of that work. We also can acknowledge at this time that while these 17 states are now participating in formal programs, at the last count, we know that 30 more states are actively pursuing a recognition process in the varying levels and stages. We know that the majority of these programs are voluntary, so it's a lot of work, but we're very grateful for that work. And the host institution varies depending on what that state looks like and the EMSC program. I thought I'd also do a quick review of the levels or stages or phases of the process. Essentially, if you are at a stage 0, no progress has been made, and you're just beginning this journey. Maybe making it a personal goal or priority in your role and just starting out. Level 1, your research has been conducted. You're maybe pulling together a champion team of like individuals who share the same goals and priorities as you, and thinking about who might be on that advisory committee. Level 2 or phase 2 is you're beginning to research your state. What is the framework in your state? Perhaps there are existing systems that you can study and learn from and maybe mimic or template for pediatric readiness as well. But really thinking about how to work through that framework in your individual state. Level 3 is thinking about an implementation plan. You're collaborating with your stakeholders, getting agreements and commitments from them. By level 4 or stage 4, you're in the implementation process, or you're really planning for that pediatric medical facility recognition formal process. And a program has been piloted or is in the works of being piloted. And then last but not least, number 5, you've successfully completed one facility that's been formally recognized through this process. So that's a quick review. Before we move on and I introduce our speakers, does anybody have any questions? I'll be watching the chat box as well, but if anybody has any questions, be sure to post those or take the opportunity now. All right, I will transition then to our speakers. So one of those states that has successfully completed their first program is Texas. So we are excited today to have Fatma Diop and Sally Snow from the state of Texas, to share with us today their successes, challenges, their story, really, if you will, on their readiness program. So take it away, ladies.
Hi, thank you, Lisa. Hello, everyone. This is Padma. Thank you for sharing a part of your afternoon with us today. It's 12 p.m. in Houston. I also wanted to thank the HRSA and the EIIC team for the invitation to share our experience on how we established a pediatric medical recognition program in the state of Texas. So as Lisa said, my name is Fatima Jouf. I'm the program manager for the Texas State Partnership. I have the honor to be co-presenting today's webinar with the wonderful Sally Snow. Can you all hear me well?
Yes, I can hear you well. Thank you.
Awesome, great. Thank you, Lisa. So we wanted to start today's presentation with just a few introductory information about our great state of Texas. As many of you know, it's the second largest state in the country at almost 270,000 square miles. Its population currently stands at 29.09 million people, with a quarter of that being under 18 years of age. So this ranks the state second in overall population and also pediatric population, right behind Utah. It does, however, have the largest rural population. We have 252 counties in Texas, with 177 of them considered as rural. Let's see what else. Well, Texas spans 900 miles from north to south, and 880 miles from east to west. I think that's as long the I-10 freeway is in the state of Texas. So if you are in El Paso, Texas, for example, you're actually closer to San Diego, California, than you are to Houston. The state also has 5 of the 15 fastest growing cities in the U.S. And as the last time I checked, it currently also has the 10 of the 20 largest cities. Next slide. Some fun facts too. Houston happens to be the first word spoken on the moon back in 1969. That's by the Apollo 13, I hope I got that right, astronaut, in what is most likely his most famous quote, "Houston, we've had a problem." Also, for 11 years in the 19th century, Texas was an independent nation. And also, as most of you know, everything really is bigger in Texas, and that includes our ranches, one of which is actually bigger than the entire state of Rhode Island. Also, the famous Dr. Pepper drink was invented in Texas. And also, interestingly, we produce more wool than any other state in the U.S., something I just learned. Next slide. Also, let's not forget that Sandy from SpongeBob SquarePants is one proud Texan. I think we might be the only state that had an entire episode dedicated to them, so that's something to be happy about. Next slide. All right, so these are our wonderful advisory committee members. We have Dr. Brian Bosham. He's our program director and a pediatric emergency medicine physician at Baylor College of Medicine and at Texas Children's Hospital. We also have Dr. Kate Remick, who quite honestly needs no introduction to this community. Also Dr. Mark Sparkman, an emergency physician at the UT Health in San Antonio. We're also very lucky to have our state EMS director, Joe Schmieder, who most of you Dental folks are very familiar with. We recently had the pleasure to bring on board Chief Roy Hunter to serve as our EMT / paramedic. Also on our committee is Sally Snow, also needs no introduction, and alongside Dr. Remick has championed pediatric readiness initiatives for years, not just in Texas, but throughout the nation, really. Last but not least, our wonderful fan reps, Sherry Santa and Angela Nelson. At the exception of myself, Dr. Basham, Chief Hunter, and Angela, I think it's safe to say that the rest of these folks have been with the program anywhere from 10 to 20 years, which truly speaks to their commitment to this program's mission and goals. And by the way, these are just the core 8 that are mandated by EMSC. We have many, many other committee members who attend our meetings and are actively advising us on our activities. Next slide. All right, with that, I will hand over the presentation to Sally, who will walk us through the historical journey of just how we got here. Sally?
Thanks, Fatma. Can you hear me okay?
Yep, I can hear you.
All right, let's go. So what I'm going to do is talk about the journey of facility recognition in Texas, which goes back a long ways, and we will get there in a second. But the 3 physicians responsible for leadership of the facility recognition journey since we got back on track in 2009 were Dr. Manish Shah, Dr. Saranya Srinivasan, and Dr. Brian Basham. Our program managers were Tony Gilchrist, Sam Vance, Joseph Santos, and then Fatma, who is our current director, or manager rather. Next slide, Lisa. So why did we consider developing a pediatric facility recognition program in Texas? Certainly such a system has the ability to increase awareness of the need for emergency departments to be pediatric ready and to establish minimum standards for emergency care. And in addition, it establishes a system to identify pediatric resources at the local, regional, and state level, and gaps in resources can then be more readily identified and addressed. So let's put some perspective on the situation in Texas. Next slide, please. As Fatma mentioned, the population of Texas is just over 29 million and covers 268,597 square miles. In 2019, the population growth was 1.3%. The top map here shows an overlay of the state of Connecticut on the Houston metro area. The bottom left shows Texas overlaid on the southwestern U.S. covering.
Part of having a night garden is sharing the work with others. Each monster gets to use.
All right, let's start over. Bottom left shows Texas overlaid on the southwestern United States, covering all of Nevada, most of Utah, California, and half of Arizona. The middle map shows Texas overlaid on the states of Montana, Washington, and Wyoming, reaching from Calgary, Canada, almost to the northern border of Colorado. The top right is Texas overlaid on the northeastern U.S., bordered on the north by Illinois, Michigan, Ohio, and extending to the Atlantic Ocean, taking in most of North Carolina, South Carolina, West Virginia, Virginia, Tennessee, and Kentucky. The bottom right shows Texas overlaid on Central Europe, reaching from Paris to Prague and Hamburg, Germany, to just north of Rome, Italy. Interstate 10 runs 880 miles from east to west in Texas, and by comparison, it's 841 miles from Dallas to Sioux Falls, South Dakota. From north to south, it's 900 miles from the Oklahoma border in the Texas Panhandle to Brownsville on the Mexican border. The funding for our state partnership grant is the same as Rhode Island and Delaware. Next slide, Lisa. There are 749 first responder agencies and 584 EMS provider agencies with thousands of vehicles and aircraft available to respond to 911 calls and interfacility transfers. Next slide. This information is projected numbers for the number of dispatches in Texas for 2020. We are looking at 5.5 million dispatches this year, over 15,000 a day, 627 hourly, which also equates to 10 per minute. And as of yesterday, we had almost 5 million patient records that had been entered into the state registry. 5 million patient records. And we're not done with 2020. Next slide, Lisa. This slide represents the number of EMS personnel in Texas and the level of practice for each group. As of September 30th, there was a grand total of 69,163 providers in our state. Next slide. The number of acute care hospitals in Texas went from 530 in 2007 to 565 in 2017. In 2013, the NPRP assessment, we had 503 hospitals in the system, which is far more than any other state in the country. Texas also has 82 critical access hospitals, many of which are level 4 designated trauma centers. 75% of these hospitals are in metropolitan areas and 25% in non-metropolitan areas. There are counties in the state of Texas with no hospital, no physician, and no EMS provider. 91% of the 80,677 beds in the state of Texas are in metropolitan areas. Next slide. Looking at designated trauma centers, we have a total of 291. That breaks down to 18 level 1 centers, 23 level 2 centers, 58 level 3 centers, 192 level 4 centers, and all of the level 1 and level 2 trauma centers in Texas are verified by the American College of Surgeons and designated by the Department of State Health Services, Office of EMS and Trauma. Next slide. We have 3 freestanding children's hospitals designated at level 1, 3 freestanding children's hospitals designated at level 2, and we have 2 freestanding children's hospitals at level 3. We have 1 children's hospital that's affiliated with the level 1 trauma center in Houston that's designated as a level 4. Next slide. So let's talk a little bit about the history of Texas EMS and trauma as it relates to a pediatric commitment in our state. In 1989, Texas passed the Omnibus Rural Health Care Act, establishing an unfunded mandate to create a trauma system. In the 11th hour of rulemaking, the Department of Health and Human Services tied disproportionate share funding to the trauma center designation process in Texas. This made it pretty mandatory for all of the lower level hospitals to participate to maintain their disproportionate share funding. Texas Children's Hospital lobbied the legislature to have children's hospitals be exempt from trauma system participation, which lasted for quite a long time. In 1991, the first Texas EMS for Children state partnership grant was funded under the Texas Department of Health Bureau of Emergency Management. In 1992, the Department of Health passed trauma rules establishing 22 trauma service areas or regional advisory councils, and I'll show those to you in just a few minutes. In 1993, the Texas legislature mandated the establishment of the first Pediatric EMS Advisory Council, or PMSAC. Between 1997 and 1999, PMSAC developed criteria for facility recognition and conducted pilot surveys in 8 hospitals. In 1995, PMSAC was rolled into what was then called the Emergency Healthcare Advisory Council. We have a tendency in Texas to sunset our advisory councils, and we've had multiple iterations of that over the years. In 2003, the latest iteration of that is called the Governor's EMS and Trauma Advisory Council. In 2009, the EMSC State Partnership Grant was moved to the Baylor College of Medicine. Next slide, Lisa. These are the trauma service areas in Texas where the regional advisory councils do the business of the Texas trauma system. The left map shows GTAC committee members in 2017, and you can see that the majority of members of GTAC's 10 committees come from the metropolitan areas. The right map shows those governor-appointed council members. Next slide. This number, 643 hospitals in Texas, is certainly a moving target. That number includes psychiatric and rehabilitation hospitals, and of those that have an emergency department, the majority are general EDs, not unlike the rest of the country. According to the NPRP assessment in 2013, only 7% had a pediatric ED and 4% were based in children's hospitals. 3% of general EDs had separate pediatric areas designated for children, and 36% of Texas hospitals had an inpatient pediatric unit. Only 28% had a neonatal ICU, and only 9% had a pediatric ICU. Next slide. So let's take a look at Texas's first attempt to bring pediatric recognition to fruition. Next slide. Between 1997 and 1999, we set out on our first journey for facility recognition. So remembering back to our history, the legislature established a Pediatric EMS Advisory Council in 1993. That committee was led by Dr. Joan Shook from Texas Children's Hospital. Dr. Shook was heavily involved in the American Academy of Pediatrics and the AAP Committee on Pediatric Emergency Medicine. She was aware of efforts around the country to bring facility recognition to other states. The committee made a decision to move forward with the development of criteria for 4 levels of recognition based on a model underway in Florida. Much work went into the development of criteria. The committee knew that a pilot project to survey some rural hospitals in Texas would give us valuable data. We received a DHHS grant to run a pilot. 9 rural hospitals were surveyed in person. I'm sorry, that was 8 rural hospitals surveyed in person in conjunction with their level 4 trauma site surveys. This process proved to be an unpopular decision with the hospitals because it stretched their personnel to their limits. As you can imagine, the trauma coordinator was also the pediatric coordinator, and it was just too much to get prepared for both surveys. One of the things we surmised from all our pilot surveys was that there was a need for helping hospitals be better prepared to care for kids. I was involved in 3 of those surveys and discovered the staff were hungry for help improving their care. One hospital I surveyed had no pediatric or neonatal non-rebreather masks in their hospitals or on any of their ambulances. Another had taken the burn policy and added the word pediatric to it. They simply did not know what they did not know, and they were very, very desperate for help and wanted it so badly. We took our findings back to the Emergency Healthcare Advisory Council and the Department of State Health Services, where we were told there's no money. If you can figure out how to fund it, it can be done. Next slide. The state partnership grant was moved from the Bureau of Emergency Management to the Office of Epidemiology. And while there were occasional presentations to the Emergency Healthcare Advisory Council on data, there were no clinical staff involved in the program, and the progress of facility recognition stopped. The Pediatric Committee of GTAC continued to tackle issues facing pediatric emergency care in the state under the leadership of Dr. Charles Macias. Meanwhile, efforts to mandate pediatric equipment on ambulances was strongly resisted by EMS medical directors who had no interest in being told what to do with their ambulances. Efforts to improve pediatric education requirements for EMS at different levels was a difficult struggle. A resolution to call attention to limiting ionized radiation and the need for the use image gently protocols was passed. The document was created and posted on the Pediatric Committee page of GTAC to limit the number of CT scans done prior to transfer. The GTAC PEDS Committee developed a document for pediatric consideration for consultation and transfer and vetted it through all the committees. The protocol that standardized the recommendations for medical and trauma transfers was approved by the GTAC Council. We continue to support the efforts of regional and state fatality review teams as well. Next slide. Some of the barriers in our early efforts included the sheer size of our state and the number of hospitals that we needed to reach. There was no statute calling for pediatric recognition, and there was no funding to support it. All we had was the evidence that there was a need. Next slide. In 2013, the National Pediatric Readiness Program was completed, and for the first time since 2003, we had data to support the need for improving pediatric readiness on a national level. Next slide. NPRP represented a national initiative. There you go. NPRP represented a national initiative to ensure the EDs were ready to care for kids based on the 2009 Joint Policy Statement of the AAP, ASAP, ENA, and the EMS for Children National Resource Center, Guidelines for Care of Children in the Emergency Department. Texas weighted readiness score was 60.5%. Our weighted readiness score was similar to the national score for all hospital volume categories. It was important for us to learn from what EDs are doing well and identify what they can do to improve in order to enhance readiness in Texas. Next slide. After NPRP, we recognized some common barriers with the rest of the country. We lacked educational resources, QI plans, and pediatric specific policies. There was a lack of awareness of the guidelines in 45% of the respondents. Hospitals lacked disaster preparedness plans, trained nurses and physicians, and lack of administrative support. Many cited the cost of training personnel as a barrier, and frankly, some were not interested in pediatric readiness at all and cited low pediatric volume as a reason for their apathy. Can't you hear them now saying, we don't see kids? Next slide, please. Moving the program to the Baylor College of Medicine in 2009 jump-started our progress again. Efforts to develop criteria for facility recognition was ongoing through the EMSC State Partnership Advisory Council and the GTAC Pediatric Committee. In 2013, Dr. Kate Remick returned to Texas, bringing her expertise and experience in California with EDAPS. She quickly offered her expertise to the Texas EMS Advisory Council. We conducted 2 webinars, the same webinar twice, in April of 2014 to develop interest in the facility recognition effort. In 2015, Dr. Remick presented to 8 GTAC committees regarding a voluntary pediatric readiness program, and unanimous support was received by the full GTAC Council in November. In 2016, Texas joined the EIIC Facility Recognition Collaborative. The program manager and 2 advisory council members representing the Children's Hospital Association of Texas and Texas ENA attended the initial in-person meeting in Washington, D.C. An initial stakeholder meeting was conducted in September of 2016 with about 30 stakeholders in attendance to identify critical factors for success, obstacles, and solutions. Our stakeholder group was very frank with us about what they saw as barriers. A second stakeholder meeting was held in November of 2016, where a World Cafe format was used to further refine obstacles and to develop a grid to determine those stakeholders with high interest and commitment and to begin to come to consensus on structure for the program. 2 additional stakeholder meetings were held in the first half of 2017 to determine criteria for the 3 levels of recognition that we had settled on. The criteria was based on the 2013 NPRP assessment results in our state. We decided to adopt all criteria that hospitals scored an average of 80 on, and criteria that fell under the 80-point threshold were individually scored by the participants for inclusion in our PEDS Ready level criteria. In late 2017, we had a program director change, and Dr. Saranya Srinivasan stepped in. We were set to conduct our pilot program using a virtual assessment program and looked at how to choose our pilot hospitals. Program leadership wanted to choose the hospitals based on the volume, low, mid, and high. The advisory council felt that soliciting volunteers would be more successful, and several hospitals did volunteer when approached. In late 2017, the bottom fell out of our program and we lost our program manager and shortly thereafter, our program director. Next slide. Something we didn't lose was our committed stakeholders. Even though we had to round some of them back up and bring them back to the table, they were there. The Texas Pediatric Society signed on early, along with the Children's Hospital Association of Texas and Texas ENA. Texas Parent to Parent had been a longstanding, very committed stakeholder and has provided support as our Family Advisory Council representatives. Texas ASAP was a latecomer to the process, along with the Texas Hospital Association. The Texas Department of State Health Services has supported us from day one, and their affiliates in the Office of Rural Health identified themselves as a stakeholder and attended our meetings. The Pediatric Committee of the Governor's EMS and Trauma Advisory Council has been a steadfast supporter, and during the time when that state partnership grant was without a program director, the only support the program received was from the members of the GTAC Pediatric Committee, who kept the facility recognition spirit alive under the leadership of Belinda Waters and myself. The Office of Trauma and EMS has supported our efforts through the leadership and support of Joe Schmieder, the state EMS director, and the hospital preparedness program has been sending a representative to our meetings since the federal mandate to collaborate. The Texas EMS Trauma and Acute Care Foundation has been a support since its inception. Next slide. The Texas EMS Trauma and Acute Care Foundation was founded in 2006 out of a need for level 3 and level 4 trauma center surveys. The state abdicated their responsibility for all site surveys to the American College of Surgeons. It quickly became evident that level 3 and level 4 hospitals in Texas would never be able to afford the cost of the ACS. So TTAF was founded and stepped up to fill that unfilled need. In 2008, the 501c3 organization was granted survey authority. In 2010, stroke center verification was added to their plate. And in 2015, they took on neonatal center verification, and maternal care verification was added in 2017. All of these programs are legislatively mandated, and hospitals were forced to participate. Despite years of discussion with us at the EMSC, TTAF advised the EMS for Children State Partnership that their ability to help us would be limited to advice on the survey process and training of surveyors, because they simply did not have the bandwidth to act as our surveying body. Just like in 1999, there was no money. This ends my portion of the presentation, but before I leave you, I'd like to say this. Our first facility recognition assessment took place on May 20th, 2020, with a virtual visit to Trinity Mother Frances Hospital in Jacksonville, Texas. Facilitators were myself and Belinda Waters, two experienced nurses with trauma site survey experience and a strong commitment to the success of voluntary pediatric readiness in Texas. The assessment lasted 5.5 hours and went very smoothly. We were able to interact with the staff at the hospital, tour the ED, conduct our credentialing review, and present our findings. The hospital has been on the PEDS Ready journey for 2 years, and they certainly set the bar for other hospitals high in Texas. For me, it was the culmination of a 27-year journey to see the first hospital in Texas recognized as PEDS Ready. Thank you for the opportunity to tell our facility recognition story. And with that, I will turn it back over to Fatma to bring us home.
All right, thank you, Sally. Yes, as Dr. Remick said, she is indeed our hero. All right, so I'm going to spend the next couple of slides just diving a little more into the stakeholder meetings that Sally mentioned just a couple of slides ago, just to kind of give you a better idea of what went on during those meetings. So after the concept was endorsed by GTAC, as Sally mentioned, a lot of stakeholder meetings and webinars were conducted where our stakeholders from diverse sets of backgrounds and organizations throughout the state really just engaged in meaningful and deliberate conversations on facility readiness. So the first stakeholder meeting was held on September 16th in 2016 in Austin, where the participants brainstormed on several issues and considerations that go into implementing a facility readiness program, but mainly in the context of 3 domains. Critical factors for success, and I hope that you can see this easily. Potential obstacles and also potential solutions. So these 3 domains were then evaluated across several categories that were felt to be critical and essential in having a successful VPRP. The categories were host organization, communications, conflicts, networking, buy-in, funding, criteria, surveyors, non-participation implications, data, and also implementation. So the results of the first meeting really provided a good baseline understanding of the structure and framework of a successful facility readiness program in Texas. Next slide. All right, so that first meeting also helped stakeholders prepare for the second stakeholder meeting that was that took place on November 18th in 2016, so just a couple of months later in Dallas. The main objective of the November meeting was to discuss and identify various stakeholders throughout the state that would serve the program well, mainly in terms of the implementation and the sustainability of a successful VPRP. To that end, as Dottie mentioned, a World Cafe format for discussion was utilized to elicit comments and input from the stakeholders, from attendees on which potential stakeholders at various levels, be it federal, national, or local, and to discuss how these individual organizations and agencies would appropriately fit within one of 4 quadrants of the stakeholders grid. So the stakeholders grid is a very useful and common tool that's used by many groups to identify stakeholders and also determine what impact and importance they would have to a certain goal or mission. So the four categories that were used in the meeting were the following: high power, high interest; high power, low interest; low power, high interest; and low power, low interest. So during the World Cafe round, the participants were first divided into five groups, and each group was instructed to provide input and identify potential stakeholders under each category. So there were 5 stations with the following categories: regulatory agencies, state-level organizations, advocacy groups, provider or professional organizations, and last, 2 hospital systems or administrations. So the specific organizations were identified, and through brief discussions were assigned to one of 4 great quadrants. So the focus of this World Cafe exercise was not only to gain a broad understanding of the stakeholder landscape when it comes to the VPRP, but to also focus on those entities that were placed in the high power, low interest category. So the importance of knowing which entities fit in that category was to focus attention and efforts on garnering their support in the hopes that their influence and leverage would benefit the successful implementation of the program. During that meeting, another important topic that was discussed was the structure of the VPRP, and essentially talk about what structure would be appropriate and effective for the state of Texas. So the group discussed whether having a single tiered system or one that would involve multiple tiers would best fit the needs of our state. After much discussion and just conversations about what other states have done, the attendees decided on a multi-tiered system to ensure that our small rural hospitals are given the chance to meet the pediatric ready level, which is the lowest level of readiness. Because the main concern was to make sure that they're not excluded from the program because of any barriers or challenges they may have in their regions, be it financial, logistics, resources, and what have you. Next slide. So the third stakeholders meeting was held on May 8th of 2017 in Austin. And during this meeting, the attendees were asked to deliberate and provide suggestions on the multi-tiered VPRP. So they were mainly asked which items on the guidelines for care of children in the emergency department from 2009 should be included in the readiness program for Texas. So adopting work done by the EIIC's Facility Recognition Program, Multi-State Collaborative, or FRC, a three-tiered system was adopted based on the following structure. Minimum criteria, attainable with support, or stretch goals. So while the VPRP adopted the EIIC framework for a multi-tiered recognition system, the decision was ultimately made to rename each level from minimal, attainable with support, and stretch goals to pediatric ready, pediatric champion, and pediatric innovator, respectively. Next slide. So prior to that May meeting, the EMSC programs office staff at the time analyzed the results of the NPRP data for Texas and cross-checked scored items that were 86% and above with matching items that were on the guidelines checklist. So for items that were scored 86% or better on the NPRP survey and also had a corresponding match on the checklist, the decision was made to identify those items as meeting the pediatric ready level of readiness. And that list of those items was actually provided to the attendees ahead of the meeting for them to review and approve. And it was actually approved by consensus during the actual meeting. The remaining items on the checklist were then presented to the participants during the meeting to decide on which level each item should be placed in, either the pediatric champion level or the pediatric innovator. So using the polling tool, Poll Everywhere, the attendees were asked to vote on each item, and the voting results were expressed in percentages of vote. So items that received 75% of votes for a particular level were then permanently assigned to that level. Every item that was voted on exceeded the required 75% threshold and was assigned to a category. The final list was then formatted into a checklist, which is what we currently are using. And Sally will kill me if I don't mention that although these items were based on the 2009 guidelines, we do have plans to update them to reflect the changes that were made with the latest version that came out in 2018. So we are working on that. Next slide. All right, so in the end, through various meetings, recommendations, the structure and characteristics of the VPRP were decided as follows. It was decided that it would be a voluntary program. And this was due to many factors, one of which Sally kind of mentioned earlier. There was no legal mandate to go along with the establishment of a VPRP at the time, or now for that matter. And also the fact that it's housed at an academic institution, Baylor, and not with an entity that would have a regulatory authority, say, for example, the State Office of EMS. It was also decided that it would be free of charge to the hospitals, at least for the time being. And I mentioned earlier that it would have 3 possible levels of recognition. When it comes to the surveying or verification process, it was decided that for the pediatric level, ready level, and pediatric champion, the verification for both of those would be done virtually, and then the last level would be done on site. The rationale for taking this approach was to mitigate the high cost that would come with having to send a team of professionals to each facility throughout the state. With the size of the state and the number of hospitals we have, this would be extremely costly. Lastly, it was also decided that the first level of recognition would be piloted first, and then once it concludes, the subsequent levels would follow one by one. Next slide. All right, so with that, we were poised to move forward with the pilot of the pediatric ready level, which brings us to 2018, which is when Dr. Basham and I actually came on board. Next slide. So ahead of the pilot launch, it really, to us, made sense to create a VPRP subcommittee that would essentially help drive our action items forward so that we can make sure to stay on track for our targeted pilot launch date. So what the subcommittee mainly worked on was filling the gaps of our implementation plan with tools that were deemed as necessary for a coherent and smooth assessment process. By the way, we use the term assessment instead of survey because as we launched the pilot, we really wanted to project the sense of the VPRP being a tool for hospitals to use to assess and increase their readiness to care for children, but it's not meant to, let's say, regulate. So instead of using this term survey, we just say assessment, which is to say we're just here to help you get better. We also use the term facilitators instead of surveyors, really for the same reason. It was actually overall just better received. So anyhow, we also created reference manuals for both our facilitators and our hospitals to use throughout the recognition process. The facilitator manual was the very first step towards having a standard facilitator training in place, which was deemed very important. Obviously, we wanted to make sure that we had a verification process in place that would remain consistent and is independent of the facilitator. So prior to the launch, we also ironed out our assessment process and put together an agenda that made sure to include all the required items that were on the VPRP criteria. And this is not on the slide, but I just wanted to mention it. As part of the assessment process, we initially planned to conduct a virtual chart reviews because, as Sally often says, you don't know how guidelines and protocols are applied until you look at the charts. So that was the initial decision. However, after much discussion with our committee members, we had decided to not do that, mainly because it just would have been logistically too complicated, especially when it came to PHI protection and HIPAA laws, obviously. So instead of that, what we did was put together a questionnaire using REDCap that includes various clinical scenarios with questions for the hospital staff to answer and essentially demonstrate their use of protocols. They actually filled it out and submitted ahead of the assessment. We also worked on ironing out our application process and timeline so as to have clear set processes and expectations for both the program and the applicants. For our timeline, for example, we wanted to have an open period during which applications can be submitted, followed by assessments, and hopefully for us to be able to make decisions on which hospitals will be recognized before EMSC Day, which most of you know falls on the third week of May, the Wednesday, right? Yeah. So this will also allow us to present certificates to cohorts of applicants at the same time, rather than one by one. So that was the initial plan. Obviously, things happen differently, and we'll get into that in a little bit. We also had a process map, essentially just maps out all the different steps from when an application is submitted, leading up to when the facility is recognized and everything in between. Again, it was important for us to have a set and clear process throughout the entire application process so that everyone involved can be on the same page. Finally, we came up with a logo and a design for window clings that our hospitals could use to display, could just use on their ED doors, for example, should they decide to display their accomplishment in that matter. I really want to pause here just quickly, really thank all of you out there, managers who were so wonderful to share your documents with us and help us out in any way that you could. I've sent countless emails and held some calls, had some conversations with many of you who already have these programs established in your states, and we're really grateful for all of your help. And likewise, I would be more than happy to share the documents that we'll put together for the program with anyone who is interested. Next slide. So we have a really good representation of stakeholders on the VPRP subcommittee. So obviously there's us, the EMSC program, and then we have Sally from the ENA. We also have Dr. Ian Mitchell. He's with ACS, but he's a doctor in San Antonio, a trauma surgeon, I believe. And he's done a lot of different surveys with TTAF that Sally mentioned earlier. And so having him on the subcommittee really helped bring his perspective on how surveys are generally done, especially in the state of Texas. We also have Joe Schmieder and Maddie, who both represent the Texas DSHS, the Office of EMS. We also had a pediatric emergency fellow. I actually recently learned that he is now an attending, so good for him. He's from Baylor College of Medicine. We also have representation from GTAC, Pediatric Committee. Previously, that was also Sally, and now Belinda has taken over from her. Very lucky to have them both on the committee. We also have a lot of folks from some of our children's hospitals also guide us in these activities. And of course, Dr. Remick is also a part of that. Next slide. So the pilot finally launched in November of 2019, which was a very interesting timing. At least for me, because that was the same time that I had to go on my maternity leave last year. But luckily for me, I had an army of dedicated committee members who were ready and poised to hold down the fort in my absence. So we initially conducted targeted recruitment focusing on hospitals that had participated in the NPRP back in 2013, and also reached out to some of the Texas facilities that were already involved in pediatric readiness efforts, namely the VPRP Collaborative. So leading up to the pilot, we also made several announcements during the GTAC committee meetings. These happen on a quarterly basis. So I think 2 meetings prior to the launch, we made sure that they were aware of where we stood, and not the pilot would be launched soon. So essentially, we made a lot of calls for applications to any hospital representative that would be interested. We also created a VPRP one-pager that was distributed to conference attendees. Just had pretty much all the information that they needed to know at the time to make a decision on whether or not it's something that they would be interested in. We also pulled qualified facilitators from our list of committee members, with the caveat that they cannot facilitate an assessment for a hospital that is within 150 miles of their residence or work location. This was just really to prevent any possibility of bias or conflict of interest. So in the end, we originally wanted 4 hospitals to be a part of the pilot. Ended up with 6. We'll always take more that were interested to participate. 5 of those hospitals did initiate the application process, but so far only 1 has completed the recognition process. And as Sally mentioned, the hospital has been, they've been working on their application for 2 solid years, and we're just committed to see the application process through. So, and I also think it's fair to assume that the pandemic may have kind of dampened some of those efforts to complete the applications. So that's something we had to work around, obviously. And on our end, I think we were very lucky that we already had a virtual assessment process already in place and ready to go. So that part was not as severely affected, I guess. The good news is that we are currently expecting 2 applications to be submitted sometime very soon, actually. All right, so just want to go over some barriers that we've had over the past, 20, 25 years. Obviously, as Sally mentioned, we had staff turnover a few times, but lucky for us, we had committee members that were so involved that with the new manager, the new director, they were there and ready to be part of the onboarding process and just keep things rolling. The size of the state, obviously, is a big barrier because, as I mentioned, we had to, from very early on, think about ways to mitigate the cost that would come with having to travel to all these hospitals. And so right along there is also the large number of hospitals too. I think we have at this time 643 emergency departments. Regulation fatigue was a barrier. So by the time the VPRP, by the time we got the endorsement for the concept, there was already a neonatal survey in place. There was a maternal survey in place, perinatal, I believe, stroke. I'm sure I'm leaving out a couple. So by the time the VPRP, we tried to establish it. People were already a little tired of having new surveys. So that kind of adds to the reason why we kind of went with the voluntary approach. No sustainability and no incentives. We're not offering any incentives to the hospitals at this time, other than just the window clean that I mentioned earlier, and obviously ways to essentially promote their accomplishment around the state. Some big enablers, as I mentioned, were having a very passionate core committee members rather, who have always been there. You can see she's been involved with this since the 1999, and obviously Dr. Remick, and all these other folks who have always been there and stayed true to this mission. Having the historical knowledge does also help to know what are some of the things that didn't work in the past that we should not repeat. Knowing gaps from the NPRP really helped with building our criteria checklist. And also understanding the state political framework really does let us know what not to do, pretty much, not to say, or things of that nature. And participating in the FRC was very beneficial in having a framework to have a implementation plan that's effective. Also, obviously, the engagement of our stakeholders, and as I mentioned, also having a virtual process in place. Lessons learned, definitely build a strong stakeholder group, leverage your local and state chapters of AAP, ENA, ASAP. I think having those folks on board will be beneficial in the long term, depending on how long it takes you to get to your first recognition. So also maintain a historical perspective, as I mentioned earlier, and definitely don't reinvent the wheel. And that's something that I learned very early on when I came to the EMSC program. There are wonderful managers who are ready to share and guide you through any initiatives that they've already done, so that you don't have to do all of it from the start when you really don't have to. So just reach out and leverage your EMSC manager community. And definitely take advantage of opportunities to collaborate. You don't know what you need from someone until you give them a chance to be involved. So just be open. Next slide. Yes, this is a stolen slide from the last presentation. I think it was from Ms. Avenue Lyons, and she just really summed it up perfectly. Success is like an iceberg. There's what people see and what really goes on, and all the background work that needs to be done for you to get to where you are. Just keep at it. Be perseverant. Be persistent. There's a lot of hard work that goes into this. I mean, I came kind of towards the end of this, and I was really, really just blessed to have it all ready for me to just go. And so if you're not as lucky, just keep the big picture in mind and know that sometime might take you 20 years, might take you 10 years, you will get to your goal eventually. Next slide. Same thing here. I'm not advocating for animal cruelty, I promise, but we all know the saying, the way to eat an elephant is one bite at a time. So just take the time to just do things right and do what you need to get to where you are. Next one. All right. So this I am a recovering what's the word, perfectionist. So definitely don't wait to have a 100% perfect program to move forward. That's what your pilot is for you to learn what works and what does not, and then adjust and then go from there. So use your pilot to assess where you are and what needs to be done next. Next slide. And also keep your committee members engaged. it's very important that you make them a part of this instead of just giving updates all the time of what's going on. Make them as involved as possible. Give them homeworks if you have, just so that the more utilized, the more involved they feel, the most likely they will stick around a lot longer and contribute to the ultimate goal of your program. Next. Just some last ones. Use your data to justify the program in your state. Many of you are lucky to be having the NPRP coming up again next year, so that could be a great starting point for you. Use the data from your state to just say, hey, here is what the data shows, and this is why we need this in our state. And again, develop and maintain those state partnerships. And as for your hospital, find benefits you think you could highlight when it comes to their participation to a program like this, and let them know this could be beneficial for you, even if I don't have any, let's say, incentives to give you. Hold applicant calls. So far, we've only actually had one, but it was really, the feedback on that was great. We gave the applicants a chance to really just ask whatever questions they had about the process, and also encourage the hospitals to get early buy-in from their hospital leaderships, the CEOs and their hospital administrators, because having that top-down commitment really does matter in the end. Keep costs in mind, how much it would be to implement this in your state, how much will it cost to the hospitals, and also how much it will be to sustain this program every year. Next slide. And that's it. Any questions?
Does anybody have any questions for Fatma and Sally? Just a comment from me, to both of you. Congratulations, such great work. Very impressive, and I think it was very informative. The information was very informative today.
All right, well, thank you, everyone.
All right, so not hearing any questions. Does anybody have any, before we go for the day, does anybody have any requests for suggestions or topics for our next call that will be here before we know it in January of 2021? My goodness.
Hi, Lisa, this is T. I just had a quick question. I actually dropped it on the chat box. But as you're also looking for future topics for the committee of practice, could we gather more information on budgets to maintain a PEDS medical recognition program? And thank you again, Sally and Fatma. That was a great presentation. I really do appreciate the level of detail that was provided today. I learned a lot. It was very helpful. Thank you.
Thank you, T. Yes, I made note of your question. So yes, we'll work on that.
Thank you.
All right, that ends our call today. Thank you to each of you for making time to join us. I know things are crazy in many different parts of the country, and you all have taken the time of your day to participate. Very appreciated. I look forward to hearing from you if you have any requests or suggestions for topics, and please don't hesitate to reach out to me if you have any needs. I'd be happy to help. Everyone have a good day.
Thank you.
Thanks, Lisa.
Thank you all.